Hello, good afternoon, everyone. Sorry for the delay. So, we just had an emergency currently, and there's a patient the doctor is operating on for just 15 minutes. So, kindly bear with us. Thank you. Hello, sorry, please. Good afternoon, everyone. Sorry for the delay. Had an emergency. This is Jeffrey of one of my pharmacies. And I work in CBA. So I manage the hypertension business unit. And today we have a CPD. And the CPD will be audited by our own Dr. Agyekum, who is a cardiologist and also a lecturer at the School of Medicine and Dentistry. So good afternoon, everyone. My name is Jeffrey, and I'm a pharmacist in Sevi. I manage the hypertension business unit, and I want to welcome you all to ECP on the optimization of the management of at-risk hypertensive patients, uncontrolled and Amlodipine. And to do this, for today, our speaker, who is a cardiologist and also a lecturer at the School of Medicine and Dentistry, and it's our very own Dr. Agyekum. Thank you very much. So Dr. Agyekum, if you can hear me, can you take over?
Okay, thank you. Can you please let my slide come on? Good. All right. Thank you very much. And good evening to you all. Sorry for the delay. There was a bit of a hitch somewhere, but thank God we've gone through it. So in the next 1 hour or so, we're going to be looking at hypertension, how to optimize blood pressure control in Ghanaian patients who are at high risk. The outline is going to be, I'm going to give a case presentation, a short one, that will be the focus of our discussion. And then we will look at what are the unmet needs of hypertension in Ghana, how can we optimize blood pressure control in patients who have hypertension, and then what do the guidelines say? We will look at some of the latest guidelines in the field of hypertension to see how to optimize our blood pressure control. The focus is for medical officers who are in Ghana, and I'm sure those outside Ghana, once you are in Africa, you're also going to benefit from this discussion. Hypertension, we do know, is a very common condition affecting about 31% of the adult population in the world, and most of it, about 2/3 of it, happens in the low and middle income countries, including Ghana. It's estimated that about 1.4 billion people are living with hypertension worldwide. Unfortunately, many people who are living with hypertension, even though we know how to diagnose it, do not have adequate blood pressure control despite the many antihypertensive medications that are available, despite the fact that hypertension is the major cause of premature death worldwide. And so there's need for us to try to at least improve the control of hypertension. So this patient was a 58-year-old businessman who had been diagnosed with hypertension for 4 years. He was on amlodipine 5 milligrams daily, which he said he was very compliant with and didn't have any problem with the medication. He did not smoke cigarettes. On examination, he was obese with a BMI of 31 kilograms per meter squared. His blood pressure was 144 over 92 millimeters of mercury, with a pulse of 84. The pulse was regular, good volume. There was no irregularity in it. The heart sounds were normal except for an S4 sound. Chest was clinically clear. Few of his laboratory investigations, total cholesterol was 6.2, HDL cholesterol 0.9, LDL 4.1. His renal function, EGFR, was 55. Urine ACR was 6.8 milligrams per millimole, and fasting blood sugar was 6.6 millimole per liter. His ECG showed sinus rhythm with left ventricular hypertrophy with strain pattern. So looking at this patient, the main issues that need addressing are, what are his main risks? If you look at this patient, he has certain risks that we need to concern ourselves with, seeing him as a Ghanaian patient with hypertension. What are his main risks? And then what should be his blood pressure goal? If we are going to control, is the 144 and if we do need to optimize and in addition to his blood pressure control, what other considerations do we need to take in managing this patient? So those are the main things we need to consider in tackling this patient. So I'll start by looking at the unmet needs of hypertension. And we do know hypertension is the biggest contributor of global burden to the global burden of disease and global mortality. And this was true in 2015, it was true in 2019, and it is true today, leading to about 10.8 million deaths each year. And the main target organs that are affected by hypertension are the heart, the kidney, the eyes, and the brain. And this may lead to complications like heart failure, coronary artery disease, renal failure, or chronic kidney disease, retinopathy, which may lead to blindness, transient ischemic attack, and stroke, and others. So hypertension is not a benign disease. It is a disease with potential complications, and we need to address it well. In addition to that, usually people with hypertension do not present with hypertension in isolation. They also have other risk factors that need addressing. Some of them may be smoking, either current smoking or past smoking, or some may have secondhand smoking. They themselves are not smoking, but people they live with or people they interact with may be smoking and then blowing the cigarette on them. Some may have diabetes in association with the hypertension, dyslipidemia, overweight or obesity, physical inactivity, and the unhealthy diet. So these are what we call the modifiable risk factors. And then the relatively fixed risk factors, hypertension may present with chronic kidney disease. People with family history of hypertension are also at risk. Increased age, low socioeconomic or educational status. So these are what we cannot modify. So we concern ourselves mostly with those we can modify and then slow down the progression of those we cannot really reverse or modify. This table for me is very important because it looks at hypertension awareness rates, treatment rates, and most importantly, control rate. Because we do know that even if you put a patient on hypertension medication and you do not target or get to your target, they are at still high risk of developing complications or hypertension-mediated organ damage. And whether you are in the high-income country, upper middle income, lower middle income, or low-income country, we know that awareness rates are somewhere around 50%. That means that we still need to do a lot in diagnosing patients with hypertension. A lot of patients with hypertension are still not diagnosed, and we need to be able to diagnose them. And even after diagnosis, just about half of them are, and in a somewhere like 13% control rate, and that is woefully inadequate. We need to up our game in trying to address hypertension. And this is true whether you are in America, you are in Europe, you are in Asia, or you are in sub-Saharan Africa. And that is why it is important for me and you to have this discussion this late afternoon. And this was a study done by Prof. Moa in the year 2000, looking at the main causes of heart failure in Ghana. And hypertension was the number one cause of heart failure in Ghana. In Kouassi, Prof. Usu also looked at the major causes of heart failure, and hypertension still the number one cause of heart failure. So it is not completely a benign disease. This data was taken from the Ghana, the demographic data, looking at our hospital data. If you look at the year 1990, hypertension was ranking like number 7 as the most common cause of death. Roll back to 2019, and hypertension is occupying the number 1 position. And it does that by causing stroke, by causing kidney failure, by causing heart failure, and the other complications that have been mentioned already. Then we look at people who are between 15 years to 49 years. And among these people, 51% of deaths are due to hypertension. 60% of death by stroke is due to hypertension. 27% of deaths by cardiomyopathy is the so-called hypertensive cardiomyopathy. 35% of deaths by CKD is also due to hypertension. So hypertension is a big burden in Ghanaian society. And when you take the age group 50 to 69 years, then it is even worse. Hypertension, 64% of deaths by ischemic heart disease was due to hypertension, 68% of death by stroke due to hypertension, and I mean, you can go on and on. 67% of death by CKD is due to hypertension. So hypertension is a big problem in Ghana that needs addressing. And maybe lastly on this, the burden of hypertension, this was a systematic review of all studies that were published between 1976 to 2020 by Prof. Bosu and his son, looking at all the publications on hypertension. They identified 85 articles between 1996 to 2020 involving 82,000 apparently healthy subjects who were aged between 15 and 100 years. The prevalence of hypertension varied among Ghanaians, depending on their region, depending on whether it is urban or rural, but it ranged from 2.8% to 67.5% among certain populations, with a poor prevalence of 27%. And they did not really find any difference in prevalence between males and females. The most important thing for me is the last statement, that of the subjects with hypertension, only 35% were aware of it. So this goes to corroborate what we have said already, that less than 50% of patients who have hypertension are really aware of it. And those who are aware, 22% were on treatment, and only 6%, 6% had their blood pressure under control. As doctors, we have a lot of work to do. If we have identified hypertension as the number 1 reason for OPD attendance, hypertension as the number 1 reason for mortality in Ghana, hypertension as the number 1 reason for stroke, for CKD, for heart failure, and other diseases, and we are only achieving 6% control rate, then there's a lot of work for us to do. So the issue is, why are BPs not well controlled? Because we do know, we diagnose it. So why are our BPs not well controlled? And the factors mainly are three. We have the patient-related factors, physician-related factors, and also the health system-related factors. This afternoon, I'm going to concern myself mainly about the patient-related factors and the physician-related factors to address. I mean, the health system-related factors also need addressing. That doesn't mean that it is less. And it could range from poor adherence to the drug therapy. Some of the patients, they are non-adherent to their medication, lack of knowledge about hypertension. Some feel that, oh, since I'm not having any symptoms from hypertension, I don't see the reason why I should take medication. Inability to engage in the lifestyle changes that are necessary for controlling hypertension, because hypertension control is not just about medications. Lifestyle changes are also important. And sometimes belief about medications and medication side effects. Some feel that, oh, when I take these medicines, I'm going to have complications, and therefore I'm not taking them. Physician-related factors, for me, the biggest issue is clinician inertia. A lot of clinicians are satisfied with just monotherapy or putting patients on medication, achieving blood pressure of 145, 146 over 90. Oh, I'm happy. Your blood pressure has dropped from 160 over 100 to 140 over 90, so I'm happy. No, that is also something that we need to watch and address. So basically, the main issues at play are the physician inertia and then patient non-adherence to medication due to several reasons best known to them. But let's look at this one. This was looking at hypertension medication optimization versus blood pressure control rate. And in places where hypertension medications are optimized, their blood pressure control rate is high. And that is why when you take a look at a place like United States, you will get control rates higher than 30% and 40% compared to in Ghana, where you are having control rates of about 6%. So where clinicians actively optimize therapy, control rates are better. This was also another study that was done in Italy looking at non-adherence or discontinuing rate of medication, like patients who have been diagnosed with hypertension newly and they've been put on medication. How many of them stopped their medications? And this was almost 63% of patients said that they have stopped their medication at a certain point in time. And then when you take a look at this real-life study that involved 80,000 residents who were newly treated with antihypertensive therapy, only 24% of them had adherence rate of more than 75%. So what that means is that a lot of the patients we are putting on treatment, they are not going to achieve their medication hypertension target because they are non-adherent to their medication. They are going to stop their medication sometimes. And it is even worse when the medications are many. We did this study in 2015 in Kolebu with Professor Vincent Boima, looking at blood pressure medication non-adherence in Ghanaians and Nigerians. So we collected data from Kolebu and other hospitals in Nigeria. And among the 357 hypertensive patients who had been referred to Kolebu, a tertiary hospital, there was poor blood pressure control rate. And this poor blood pressure control rate was observed in almost 70% of patients. So this was Kolebu Physician Clinic. 70% of patients who were attending the clinic did not have their blood pressure target. And moreover, medication non-adherence was found in close to 67% of patients. So even though they were coming to the clinic, even though they were taking their prescription, they were not taking their medications. And some of the reasons are sometimes the medications are too many for them. Sometimes they are difficult to swallow, and so they are not taking it. So the next question I want us to discuss is, what is the importance of a single pill combination according to the guidelines? So now we have seen that Hypertension is common, its control is poor, and this is partly due to clinician inertia and patient non-adherence. So, what role will combination therapy play if you look at the guidelines that have been presented to us so far? With the new guidelines, 2018 European Society of Cardiology guidelines, we do know that even hypertension targets have become even tighter, with your first target below 140 systolic, and then if patients can tolerate it, you go to below 130 millimeters of mercury as much as possible. You don't want to drop your blood pressure below 120 millimeters of mercury for most patients, and this is applicable to patients who are less than 65 years. For those who are above 65 years, you are looking at a target of 140 over 90. If they can tolerate it without any untoward side effects, you may still go to 130 over 80 millimeters of mercury. And if you look at the sprint trial, which made a lot of impact, we compare the intensive arm to the standard arm. And we do know the intensive arm was more beneficial to the standard arm. Now look at the number of medications that they needed. The intensive arm needed an average of 3 antihypertensive medications, whereas the standard arm needed an average of 2 antihypertensive medications. What that means is that most of your patients are not going to get to target with your single antihypertensive medication. Majority of your patients will need 2 or more antihypertensive medication. No wonder our businessman did not have his blood pressure under control because he was on monotherapy. Now you take a look at this study that was also done looking at how likely are patients to achieve their medication target when they are on monotherapy versus dual therapy versus triple therapy. And I mean, it is no news to say that those who are on triple therapy, whether they are younger patients 18 to 65 years or older patients more than 65 years, are more likely to achieve their blood pressure target than those who are on monotherapy or dual therapy. So what are the pros and cons of single pill combination therapy? So now we have seen that most of your patients are not going to get control with single therapy. You need 2 or 3 antihypertensive medications. We are now looking at putting them in a single tablet versus giving them as individual tablets. What are the pros in single pill combination therapy? You have fewer tablets to take. And remember, when patients have to take many tablets, they are more likely to be non-adherent. Lower doses of component drugs. The higher the dose of any antihypertensive medication, the more likely the side effect. So if you are using lower doses of multiple drugs in a single tablet, the side effects are going to be less. Comfort to the patient in swallowing 1 tablet versus taking 2 or 3 tablets at the same time. Reduces clinician inertia. You know, a lot of clinicians, it takes a lot of energy to add a second antihypertensive medication or a third antihypertensive medication. So if you are starting with a drug that already contains 2 or 3 antihypertensive medications, then somehow clinician inertia is addressed. The next time is just about optimizing the dosing of the same medication rather than adding another medication to the therapy. And of course, it begs to say that it also improves adherence, and eventually you are going to have a lower cost. We may have to discuss this further. In Ghana here, the WHO has added single pill combination therapy to its essential medicines list. And so these medications must be part of country's essential medicine list. And once you are on single pill combination therapy, you are more likely to achieve your blood pressure control earlier than if you have to go slowly on monotherapy and adding them one by one. But what are the problems that are associated with single pill combination therapy? It gives you lower flexibility in adjusting your doses. So sometimes you want to just adjust one dose and then the other one is also there. So sometimes it gives lower flexibility. But these days they have various combinations. So you may have amlodipine 5 milligram, amlodipine 10 milligram, and then another medication, maybe hydrochlorothiazide, maybe lisinopril, maybe perindopril, and various combinations, so that you can choose depending on the doses you want to use. The other thing is problems with establishing the source of adverse effects. If you give a single pill combination therapy and a patient complains of side effects, and these are the problems that are this steady pill combination therapy achieving targets. Single pill combination components, they were more adherent, they were more persistent with their therapy 1 year, 6 months after on. They were more likely to achieve their systolic blood pressure, diastolic blood pressure, and overall blood pressure targets. So single pill therapy leads to improved adherence and persistence compared with the free component therapy, and may lead to better blood pressure control. Then this study was also done looking at fixed low dose triple combination antihypertensive medication versus usual care. And the usual care was also looking at these same medications, but in individual components. And of course, if you look at it, those who were on the triple pill combination therapy, 70% of them achieved their blood pressure target within the short period that this study was done, compared to only 55% of patients who were on the same medications but a single individual tablet. So this probably also indicates that some of them were not taking some of the medications if they had to take 3 different medications at the same time. So the question now is, single pill combination, we know, is better than individual components. Single pill combination gets your blood pressure controlled. Patients are more adherent. There's really no evidence that it has more side effects. But why are we still underusing single pill combination therapy? Is it the fear of adverse drug reactions? But we do know the adverse drug reactions, though, and they are expected, and we understand them, and they can be avoided. And as I said, if you are using lower doses of single pill combinations, even your adverse drug reactions are less likely than if you are using higher doses of monotherapy. This was to look at patients who were willing to trade off some of their days on earth for taking multiple medications. And 8.2% of adults, they would rather give up 2 years of their life to avoid adding one daily pill to their tablets. So even if you can reduce their pill burden by a single tablet, they are happy with it. And so patients like fewer tablets, but clinicians are reluctant in prescribing these single pill combinations that have been known to achieve results. So the next thing is, what classes must be preferred in combination? We've looked at, now we do know that you need multiple medications to be able to achieve your target. So what classes must be preferred? I love this diagram. It's a very old diagram, but it still has a lot of relevance. It tells us the green lines are the drugs that can be combined. So you can combine thiazide diuretic with calcium antagonist or calcium channel blocker. You can combine thiazide diuretic with angiotensin receptor blocker, or thiazide diuretic with ACE inhibitor, or you can combine ACE inhibitor with calcium channel blocker, angiotensin receptor blocker with calcium channel blocker. The red is what must not be combined. So you should not combine an ACE inhibitor with an ARB. That is not a recommended combination for controlling hypertension. And then other possible combinations that may not be as preferred, but if patients have issues with other medications, then those combinations may be considered. So something like beta blocker with a diuretic, beta blocker with angiotensin receptor blocker. Of course, if the patient has ischemic heart disease, then you are going to be looking at a beta blocker with an ACE inhibitor or beta blocker with an ARB. So some of these things you also have to take into consideration the patient peculiarities. So the European Society of Cardiology Guidelines 2018 gave us this important slide that looks at hypertension management for the core drug treatment strategy for uncomplicated hypertension. So if you are looking at this, they give us that we should do a stepwise approach in the management of hypertension. And this stepwise approach is, the recommended is as much as possible in step 1 and step 2, do single pill, one pill. But most patients, about 90 to 95% of patients, will need dual therapy to start with. And this dual therapy may either be an ACE inhibitor or ARB plus a calcium channel blocker or a diuretic. If the blood pressure is not well controlled, then you will look at going to step 2. As much as possible, step 2 must also be a single pill if you can do that. And that is 3 medications, ACE inhibitor or ARB, plus a calcium channel blocker, plus a diuretic. And as much as possible, this must be a triple combination therapy, single pill therapy. By the time you get to step 3, you are diagnosing resistant hypertension. And for these patients, they are recommending that you do 2 pills. So your single pill triple therapy plus spironolactone or another medication. The preferred agent will be spironolactone or eplerenone for a mineralocortical receptor antagonist. So this is the algorithm you are going to follow for most of your patients. The issue is, they said ACE inhibitor or ARB. Are they the same? Can we just choose any of them? They said CCB or diuretic. Are they the same? Can we just choose any of them? So those are some of the nitty-gritties we'll be looking at in the few slides to see whether there are some differences in some of these medications. I start off with the All Hearts trial, which is a very old but very popular hypertension study that looked compared a diuretic, calcium channel blocker, and an ACE inhibitor in patients with hypertension. And they were looking at 5 years outcome. And the primary endpoint was fatal coronary heart disease or non-fatal myocardial infarction. They followed these patients for 5 years, and there was no difference in outcome. So as far as monotherapy is concerned, whether you are starting with a diuretic or you are starting with a calcium channel blocker or you are starting with an ACE inhibitor, they did not find any difference as far as the outcomes were concerned. The line was flat throughout the period. Now comes the Ascot trial, And this ASCOT trial compared atenolol amlodipine, atenolol thiazide combination versus amlodipine perindopril combination. And as you can see, the amlodipine, that is calcium channel blocker, perindopril, that's an ACE inhibitor combination, was better than combining a beta blocker and a diuretic. So not all combinations are the same. Some of them perform better than others. And if you look at those who had stroke, the difference was even more. So fatal and non-fatal stroke, the amlodipine perindopril combination was better than the atenolol thiazide combination. Then we take a look at the accomplished trial. So accomplished trial, then look at, okay, let's look at benazepril, that is an ACE inhibitor, hydrochlorothiazide is a thiazide. So benazepril, hydrochlorothiazide, ACE inhibitor, diuretic combination versus ACE inhibitor, calcium channel blocker combination. And then they were looking at patients who were high risk for living with systolic hypertension. And then they gave these patients these medications and followed them up. The mean blood pressures after those adjustments were 131.6, or let's say about 132 millimeters of mercury, 73 millimeters of mercury in the benazepril amlodipine group, and 132 over 74 in the benazepril hydrochlorothiazide group. However, when you look at the composite endpoint, cardiovascular death, myocardial infarction, and stroke, the ACE inhibitor calcium channel blocker combination was better than the ACE inhibitor diuretic combination in this particular study. So an amlodipine-based regimen provided greater benefit than the diuretic-based regimen. So not all combinations are the same. And this is the various components of the accomplished trial. So you look at it and you see that in terms of various outcomes, composites of death from cardiovascular causes and cardiovascular events was favored ACE inhibitor amlodipine versus the ACE inhibitor diuretic combination. Purely study. This was a purely African study. So they look at 10 centers in 6 African countries, sub-Saharan African countries. They were randomized into single blind 3. So they had these medication combinations: perindopril hydrochlorothiazide, so that is ACE inhibitor diuretic combination, calcium channel blocker ACE inhibitor combination, calcium channel blocker diuretic combination. So you are looking at these 3 combinations to see whether they are the same. And this one, they monitored their blood pressure with 24-hour ambulatory blood pressure. So baseline 24-hour ambulatory blood pressure, and they repeated that in 6 months to see. And in Black patients in sub-Saharan Africa, amlodipine plus either hydrochlorothiazide or perindopril was more effective than perindopril plus hydrochlorothiazide at lowering blood pressure at 6 months. So not all combinations are the same. So by so far looking at these studies, you see a certain pattern. If you have amlodipine or calcium channel blocker based combination, whether with ACE inhibitor or with a diuretic, it is better than when you have the diuretic based combination with ACE inhibitor or ARB. This was the pianist study that also looked at triple combination, perindopril, indapamide plus amlodipine as a single therapy, and looking at the rate of blood pressure control within 4 months. And then within 4 months, these patients has had a significant reduction in their blood pressure control, with 72% of them achieving their blood pressure target. So if you really want to achieve your blood pressure target, then these combinations, they do work. You will be able to get your blood pressure under control. This table is a little busy, but it helps us to also appreciate some of the triple combinations that are available, and then the control rates that were achieved with the study. So we have amlodipine, valsartan, hydrochlorothiazide. This was by the SI study. They recruited over close to 10,000 patients, and this combination, they were able to achieve blood pressure goal in about 71% of the patients. If you take a look at amlodipine or valsartan hydrochlorothiazide combination, sample size about 6,000 patients, they were able to achieve 67.5% blood pressure control rate. Take a look at amlodipine, perindopril, and dopamine combination. That was the pain study. They were able to achieve up to 80% blood pressure control rate. And then the pianist one is what I mentioned to you. Also, amlodipine, perindopril, and dopamine combination, they were able to achieve 72% blood pressure control rate. So whichever way you look at it, if you combine the antihypertensive medications into a single tablet, they do work. And that is the key message I want to drive home here. Now, the issue is, I've mentioned, so you do know now that the guidelines say ACE inhibitor or ARB. Question is, are they the same? ACE and ARB, are they the same? Calcium channel blocker or diuretic, are they the same? I think by now we've answered this side of the question. So the next side is, are they the same? We have looked at several of the other evidences to see. And I mean, by now from medical school, we know that the ACE inhibitors and ARBs are not the same. There are other processes through the bradykinin pathway associated with ACE inhibitors that are not available in terms of ARB. So they are not the same medications. And I don't want to go into so much detail. Our time is almost spent. But let's not forget, way back in 2017, there was this ARB paradox, where if you look at the ACE inhibitor studies versus placebo, you were seeing significant reductions in cardiovascular outcomes. And these were several studies: MI, cardiovascular death, all-cause death. You look at them, all the ACE inhibitor studies, you see significant benefit. In the ARB studies, you were not seeing that. If you look at MI in the Bangalore study, there was only 7% reduction in MI. CV death there was no reduction at all. All-cause death, no reduction at all. So we cannot really say that. And this is what they describe as the ARB paradox. We cannot say that they are the same. And that is why the guidelines still recommend ACE inhibitors. But if patients cannot tolerate ACE inhibitors, then you go for ARB. So they are not the same. Now we do have some new data in terms of ACE inhibitors versus ARBs. In 2020, new publications came out, meta-analysis of 46 trials with over 248,000 patients. And then if you look at the outcomes, they were looking at all antihypertensives, ACE inhibitor, calcium channel blocker, beta blockers, ARBs, diuretic, and you are looking at the cardiovascular myocardial infarction. You can see that ACE inhibitor was better than all the other combinations and the other drugs, sorry. Then you take a look at this study that also look at 3,000 patients with myocardial infarction and dyslipidemia after coronary stent implantation, and those who were on ACE inhibitor medications were better than those who were on ARB combination. And you do remember in the new guidelines for heart failure management, the European Society of Cardiology, ACE inhibitor or ANI, if they cannot tolerate any of them, then you consider the addition of a replacement with a beta, an ARB. So these cannot be the same. And this is what I've summarized here. So this was guidelines from CHEST, and they said that if patients cannot tolerate ACE inhibitor, then you switch to an ARB. You cannot treat the two of them as the same. So another study that looked at, are all diuretics the same? And we do know by now that not all diuretics are the same. This was a study that compared indapamide versus hydrochlorothiazide versus chlorthalidone in blood pressure reduction. And hydrochlorothiazide about 9 millimeters of mercury, chlorthalidone 13 millimeters of mercury, and indapamide 14 millimeters of mercury. So you can see that not all of them are the same. There is difference. Chlorthalidone showed a numerical but not statistically significant greater reduction of systolic blood pressure compared to hydrochlorothiazide, whereas indapamide showed a statistically significant reduction in systolic blood pressure of close to 54%. And then this was a study that looked at these diuretics combination in terms of cardiovascular outcome, stroke, cardiac events, heart failure, and of course, the thiazide-like diuretics were better than the thiazide-type diuretics. So we are looking at indapamide, chlorthalidone were better than either hydrochlorothiazide or benzofluazide. So these are not the same medications. When BPs are difficult to control, some of these little changes also do help in achieving your blood pressure. I'll be rounding up very soon. What do the guidelines say? I think I've taken you through a lot of the European Society of Cardiology guidelines, so I'm not going to go through it again. And it is consistent with the 2020 International Society of Hypertension guidelines. They also recommend in step 1, that's here, step 1, dual low dose combination. And they are saying that it should be a single pill combination. So they are looking at A plus C. A is either ACE inhibitor or ARB, and C is a calcium channel blocker. So they are saying that you should start with a combination of A plus C. And then step 2, optimize the dose of A plus C. In European Society, step 2 is add a third agent. These people are saying that step 1, start with a low dose. Step 2, optimize the dose of A and C. So if you have amlodipine plus, let's say, perindopril 5 milligrams, then step 2 is to go to the 10 milligram combination. And then step 3, add a diuretic. And then they make a comment. If you go to the diuretic comment, you see that thiazide-like diuretics are preferred. Then step 4, if the patient's blood pressure is still not well controlled, then addition of spironolactone is what is recommended in this guideline. And it could be from anywhere from 12.5 milligrams to 50 milligrams once a day, provided their renal function is fine and their potassium level is also fine. If the potassium is high, you will not be able to introduce spironolactone at this stage. And this is also the 2019 NICE guidelines for hypertension. They also did a stepwise like that. They were a bit more conservative. So step 1, for those who are white, those who are less than 55 years, ACE inhibitor or ARB. If the patient has type 2 diabetes or patient is not of African origin. But if the patient is of Black origin, then you are looking at calcium channel blocker as a single therapy. So this is the only guideline I see around that still recommends monotherapy as initial for your step 1. Most of the other guidelines are recommending that for most of your patients, 90 to 95% of your patients, you need to start with a dual combination therapy. So two drugs in a single pill is what you'll go for. So lastly, how do we manage our patients? So after taking you through all these guidelines, we have these patients. So our patients, I did a calculation of his 10-year ASCVD rates. And you see, when you see this patient, the values are not so high. Cholesterol is 6.2, blood pressure 144, that kind of thing. But when you do the total cardiovascular risk assessment, then you see that this patient has some risk. So his 10-year ASCVD risk is 17.8%, which puts him in intermediate risk. But in addition to that, this man is obese. Obesity is not fed into the risk calculator. Of course, this lipidemia is fed into it, hypertension is fed into it, impaired fasting glucose. So these combinations is metabolic syndrome. And this patient, metabolic syndrome, hypertensive with metabolic syndrome, is a high-risk patient. In addition to that, his ECG is showing left ventricular hypertrophy, and that is hypertension-mediated organ damage. So once you already have hypertension-mediated organ damage, that patient is high-risk patient. And on top of this, this man has proteinuria already with eGFR of 55. This means that he has CKD stage 3. So for all intents and purposes, this patient is a very high-risk patient that you need to be aggressive with. If you lose guard, you are going to lose this man's kidney. You are going to have this man develop other complications of hypertension. So that is the way to approach this patient. Once you appreciate the totality of the patient, then you'll be able to address his problems. So I put this one here from the European Society of Cardiology guidelines, and you see that this man already has hypertension-mediated organ damage. He has CKD stage 3. We haven't diagnosed diabetes yet, but his fasting blood sugar is 6.8. We will have to repeat it and see. And so this man, his blood pressure is around 144. So he is a high-risk patient, and we need to appreciate that and manage him as such. And so the target for this patient, as I've already indicated, is going to be less than 130. He already has CKD. We are looking at less than 130 millimeters of mercury for this man. He's probably having diabetes. We haven't diagnosed it yet, but this month definitely we need to bring his blood pressure to below 130 millimeters of mercury. Your distance is not advancing again. Okay, so for me, the ideal single pill therapy for this patient will be a calcium channel blocker plus an ACE inhibitor. I am not going to increase his amlodipine to 10 milligrams. No, I'll rather add an ACE inhibitor to the amlodipine. And I will prefer that these two medications are in a single tablet so that he still maintains his single tablet he's taking for his medication. Because his cardiovascular risk, ASCVD risk assessment shows intermediate risk, this man needs moderate intensity statin therapy. So we are going to add an atorvastatin or a rosuvastatin medication to his medication. And it will even be better if you have a single tablet that contains amlodipine, ACE inhibitor, plus atorvastatin or rosuvastatin. You still maintain him as a single tablet, but tackling a lot of his problems. He needs lifestyle modification. He needs to be physically active. He needs to lose weight. His BMI is 31, so he needs to work on that and lose weight. You need to reassess this patient's blood pressure in 1 month. And if the blood pressure is not well controlled, we upgrade to a single pill triple therapy. So instead of adding another medication to his medication, I will change from a single pill that contains 3 medications: calcium channel blocker, ACE inhibitor, plus a thiazide-like diuretic, preferably. Reassess his blood pressure control in 1 month. If this patient cannot tolerate an ACE inhibitor, however, then I will choose a single pill therapy that contains calcium channel blocker, ARB, plus a thiazide-like diuretic. If not controlled, after your reassessment, this patient needs reassessment. Is he taking his medication? Is he compliant with his medication? Are we dealing with a secondary hypertension? Are we dealing with a white coat effect? So we need to do ambulatory blood pressure to assess his blood pressure. If genuinely the blood pressure is not well controlled, the ideal fourth agent will be a mineralocorticoid receptor antagonist. So in this case, either spironolactone or eplerenone. I will start from 25 milligrams once a day. So, in conclusion, hypertension is a common condition. Control rates are poor, and then we have discussed the contribution factors to the poor control rate and the use of combination therapies, irrational combinations, physicians' therapeutic inertia, and poor adherence to treatment. Combining antihypertensive agents from two different classes has been shown to result in approximately 5-fold greater blood pressure reduction versus doubling the dose of a single agent. And that is why we are not going to double his amlodipine, but rather add another medication. Current guidelines recommend the use of initial dual combination therapy in most patients. And dual combinations, if they do, sometimes will not achieve your target. So if you want intensive control, then you need a third agent, and that will require a single pill triple combination therapy. And they are generally well tolerated, safe, and improve adherence, leading to better and long-term control for hypertension. Thank you very much.
Okay, thank you very much, Dr. Agyekum, for this insightful presentation. But before we take the questions, I would like to present on some few slides, then we can move on. So, the place of coveram in the management of this kind of patient, with your hypertensive patients who are high risk and uncontrolled on amlodipine.
Oh, okay, so I spoke for 1 hour. I'll get some water.
So, as Dr. Agyekum mentioned earlier, this patient is clearly a high-risk hypertensive patient and requires treatment. And from the ESH guideline, you either from the ESH guidelines, you do either do an ACE or an ARB plus a CCD. But severe provide a solution for this kind of patient, whereby we have our coveram range of antihypertensive. So the coveram is made up of amlodipine and perindopril. So now the question is, why perindopril? Perindopril, which is Kouassi, is that inhibit both plasmatic and tissue angiotensin converting enzyme and has a prolonged plasma ACE inhibitor, resulting in a decrease in angiotensin 2 levels, so a decrease in vasoconstriction. And due to its high lipophilic nature, Kouassi has the highest tissue affinity to vascular, renal, and cardiac local ACE, with less affinity to the local lung ACE inhibitor. So in this case, when you initiate perindopril for your patient, there's less incidence of cough, unlike the other ACE inhibitors. So then perindopril is being referred as the reference of the RAS inhibitor. So this diagram shows a mobile mortality trial which was being conducted with both the ACE inhibitors and the RAS inhibitors. And from the diagram, we can see that perindopril showed a positive outcome, a more positive outcome compared to the other RAS inhibitors. So perindopril is being referred to as the RAS inhibitor compared to other RAS inhibitors. So here is the cardiovascular continuum, whereby we can see from when the patient is being right diagnosed with hypertension with other comorbidity. So when the patient gets to an end-stage heart disease, perindopril has proven itself across this cardiovascular continuum. So it's been evaluated in severe morbid mortality trial. So with Covram, which is being made up of amlodipine and perindopril, when you initiate Covram for your patient, you provide your patient, or you give to your patient, a powerful blood pressure control, which is being seen after 3 months. And as in after 3 months, your patient's SBP is being reduced to 52 millimeter of mercury. And also on top of that, we give to your patient a powerful cardiovascular protection, which can be seen even after 20 years. That is 7% reduction of cardiovascular events and 18% reduction of stroke. So severe, we have different ranges of the perindopril arginine, which comes in a plain perindopril 5 and 10, which is Kouassi. And in combination of amlodipine, we have Covram. So Covram has 4 different strengths. So we have the 5.5, 5.10, the 10.5, and the maximum dose being 10.10. And also we have our triple combination, which is being called triplism and comes in 4 different strengths. So that one, so we have 5, 1.255, 5, 1.25, 10, and 10, 2.55, and the maximum dose is 10, 2.5, 10. Thank you very much. So we'll take your questions and Dr. Agyekum will answer them. Yes, please, you can have the link. So we'll make it available and email it to each and everyone who requests for it.
Okay, so somebody is asking whether any of the SPCs are on our essential medicines list. For now, the only one I know is lisinopril hydrochlorothiazide combination. I've seen that one. Apart from that, I don't know of any of the other ones. And this is something we are in discussions. We had a hypertension roundtable that we are pushing for all these essential medicines to be added to the essential medicines list. So single pill combination, amlodipine ACE inhibitor combination, amlodipine ARB combination, amlodipine diuretic combination. These ones we need them. And then triple combination. There's no triple combination in our essential medicines list. Thank you. Are there any other questions?
So, so we have one question here from Dr. Asid. Does perindopril have the same incidence of cough as compared to other ACE? So as I shared earlier, so perindopril, because of its lipophilic nature, its affinity is more towards the cardiac and renal and has a less affinity towards the lung ACE inhibitor, as in the lung ACE. So when you initiate perindopril for your patient, there's less incidence of cough for your patient. I don't know if I've answered this.
But that doesn't mean that the patients cannot cough. If they do cough, the guideline is that change to an ARB. Our questions are done with. Where is your messages track so that we see whether there are any questions under messages?
Okay, thank you very much for joining this meeting, and thank you very much, Dr. Agyekum, for your time. We'd like to see each other again sometime. Have a nice evening and enjoy yourself. Thank you.